Let me shift emphasis now to Matt. Matt works with us in the catheterization laboratory. He works with our surgical colleagues in the operating room, so he really does have a unique perspective. And there are other ways to get this valve into the heart without doing open surgery. So maybe, Matt, you can describe what we call the transapical technique and also the environment that we've created in order to do these procedures.
Sure. The transapical procedure uses really the identical technology that Jeff described, but we're coming from really the other direction. And I think this approach is particularly useful in patients who don't have the arteries in their legs of sufficient size. So the catheters that we're using for this are larger than we use for a typical coronary angioplasty procedure. So there are patients who are smaller, have a lot of calcium in their arteries, and these are the patients that I think are best suited for this transapical approach. And the concept behind this is to go actually directly in the tip of the heart and insert the valve that way. Let me show you an animation of the procedure here. So here you see the patient, same heart that Jeff saw earlier with this calcified valve. So here's the apex of the heart. So we're going to approach from the heart itself rather than coming kind of backwards through the valve as we do with the transfemoral approach.
So you make a small incision.
So small incision in the left side of the chest. It's only 3 to 4 centimeters large, and then we insert the needle and then the sheath directly through the tip of the heart, and we place some sutures there. So at the end, when we remove it, we can close off that hole. But we cross again with the same kind of wire. Use a balloon, as was done in the other procedure, to kind of open up the valve to prepare it to accept the catheter valve. And then through the sheath, this is the same catheter valve. It's facing the opposite direction as it was with the transfemoral procedure, and deploy the valve. And it essentially, at this point, the valve is identical to the other procedure. We're working much closer to the valve, and there are components that make this a little more simple. We would then remove the sheath and obviously tie these sutures, and that prevents any bleeding from the heart. And now we have a functioning valve without any further aortic stenosis.